Okay. So this webinar is going to be recorded and we will have it available for all of you in our YouTube channel and in our webinar library at the RHSC website. We will share with you the link to the recording. Do not hesitate to contact me or my colleague Laura Mayer if you have any technical difficulty with the Zoom. Please remember to keep your microphones off. With further ado, I would like to welcome Dr. Metin Gülmezoglu. Metin is the Executive Director of the Concept Foundation, and he's the chair of the Maternal Health Supplies Caucus. Metin will make the presentations to our panelists. Thank you, Metin.
Thank you, Milka, and welcome everyone. And I'm very happy and pleased to host you or moderate this webinar. We have 90 minutes to talk about preeclampsia. And before we started, I was thinking about preeclampsia discussions in the past. And I think in the past, we always talked about whether magnesium sulfate is available at 20% or 50% solution, and magnesium sulfate administration difficulties and quality issues and so on. So it is a real sort of refreshing look to deep dive into preeclampsia commodities and some new developments in the field. So we have 3 speakers and 90 minutes in total. Our speakers will talk around 15 minutes each, and we will take 1 or 2 questions after each talk, but I'm hoping that we will have some general discussion opportunity once the presentations are finished as well. So with that, I'm going to introduce our first speaker, who is Kelsey Barrett. And Kelsey is a technical officer at Unitaid. Unitaid, I'm sure most of you are familiar with Unitaid's work in HIV, TB, malaria. But for the last couple of years, I think it has been welcomed by all of us that Unitaid prioritized sexual and reproductive health and maternal health in particular. Kelsey is in the strategy team at Unitaid, and she has a master's in public health, and she has worked at PATH, and she's worked in the field in Senegal for an NGO in the past. And she has been managing the preeclampsia portfolio at Unitaid. Kelsey, over to you.
Thanks so much, Metin, and it's great to have this opportunity to present to all of you today. I see so many familiar names and faces, so I'll dive right in. So I'm going to present some background first on preeclampsia to kind of ground us all in the discussion, and then give an update on some recent landscaping that we've done, as well as looking at some of the barriers to pre-PE care and opportunities to better address preeclampsia in low and middle income countries. So we could go to the next slide, gives an introduction on PE. So we know that one of the key reasons that focusing on preeclampsia is so critical is because of the heavy public health burden that it causes. We know on a daily basis that 800 women die every day due to complications in pregnancy and childbirth, with the vast majority occurring in LMICs. And that preeclampsia is the second leading cause of maternal mortality after postpartum hemorrhage. This also varies by geography, and in some regions like Latin America, preeclampsia is the #1 cause of maternal mortality. So every year we see about 76,000 maternal deaths and 500,000 fetal and newborn deaths due to preeclampsia, and it's strongly associated with infants being born low birth weight or preterm, making them prone to many early morbidities. So I think we're all across this, but preeclampsia is a hypertensive disorder that occurs in pregnancy, and if it's not detected and managed well, it can progress to eclampsia during delivery, and that can include seizures and strokes. And another important point to mention is that preeclampsia cases are increasing, and this is due to many factors like the rise of non-communicable diseases, but it's also linked to factors like climate change. We know that exposure to heat extremes or poor air quality, salinity in drinking water from coastal flooding, they all increase risk of preeclampsia. So it's an important consideration as well. And it's a highly prioritized area of need. We've been hearing it at Unitaid from many partners about how there's desire to do more work on preeclampsia from community and civil society stakeholders as well. And there's been a groundswell of support from calls to action at conferences to front page news stories, as you see here in Rwanda. And a theme in these conversations is that we're seeing progress and attention and momentum really building on postpartum hemorrhage, and this desire to see similar progress and focus on preeclampsia next. And it's also an issue that hits home for many. I think it's really very relatable just how common hypertensive disorders are. And, unfortunately, preeclampsia as well. My own mother had preeclampsia in her pregnancy with me, and I was a preterm baby. And those kind of personal stories come up a lot when you're speaking to people that work on preeclampsia and maternal health as well. So there's real opportunity to better manage this condition. So this slide jumps to some of what we're doing at Unitaid on preeclampsia. So we've been interested, and as Metin was saying, since about 2020, we've moved more concretely from just focusing on HIV, TB, and malaria to having some concrete focus areas in reproductive, maternal, newborn, and child health. And back in 2021, we released our first thematic narrative, which is what we call like our strategy document for an area that spoke to RMNCH and included different opportunities where investment could really make a difference. And preeclampsia was highlighted there. It was also captured in our latest 5-year strategy, which runs now through 2027 as a high priority area. And then among the programmatic priorities where we make investments, women's and children's health comes out clearly as one of the main pillars, with a priority called improving access to better tools for safe pregnancy and birth for women and newborns. So this is our work on postpartum hemorrhage falls within this category, and future work on preeclampsia fits here as well. And the exciting kind of development in the last year for us is we've done some refreshed scoping on preeclampsia. And we've also taken to our executive board another investment case for doing work in this area. So we now have approval as of June to launch calls for proposals that would focus on preeclampsia. So that's really, really exciting for all of us. And we look forward to putting together calls for proposals in the next few months. So as part of that work around the investment case, we also hired some consultants at CEPA, the Cambridge Economic Policy Associates, and I see Charlotte Warren is on the call. She was one of the lead consultants for this work, and also Suzanne Fournier. And they've been working on conducting a landscape assessment for us that looked at gaps and opportunities to better address preeclampsia. And that included, a lot of desk research, but also a lot of interviews and partner consultations with many here I see on the call, with diverse groups of researchers and manufacturers and policymakers, a range of different stakeholders, WHO stakeholders, for example. And we also had the landscape compiled and then reviewed by many partners as well. So it's great to have that kind of partner engagement and support while developing this. And our landscape assessments, we do them for many different areas, but they're meant to be kind of a public good and resource that speak to those gaps and opportunities to kind of give direction to the space, other partners that may be interested in making investments or working in the area. And they're also a great way for us to really engage with the community and hear your feedback on opportunities you think are important that maybe aren't captured, so we can continue to refine and kind of align on a common vision for work in the space. So I'll dive now into the landscape assessment itself, begin with a look at the preeclampsia care pathway. It starts with assessment looking at the different gestational age of the pregnant woman, understanding screening needs to take place first. So in low and middle income countries, preeclampsia is generally diagnosed with high blood pressure and protein in urine. Women who are recognized to be at risk will have their blood pressure more closely monitored, and if appropriate, antihypertensive drugs are prescribed. For women with severe preeclampsia or who have progressed to eclampsia, magnesium sulfate is administered for treatment and delivery. There are challenges with magnesium sulfate, just like Metin was speaking about at the outset with the complex dosing regimen and things like that. On the prevention side, there's some newer recommendations in support of administering low-dose calcium to women that are living in areas with low dietary calcium. Also low-dose aspirin is another preventive option as well. And as we thought about this care pathway, many specific innovations are profiled in the landscape. So some of the recent innovations are advancements in biomarker-based testing with markers like placental growth factor and SLIT1. These are mainly available now in laboratory-based tests, but there's also advancements in making point-of-care ultrasound more accessible for more accurate gestational age assessment, and innovations in other tools like blood pressure measurement. There's a device called the OptDVP that supports blood pressure measurement by mobile phone. Also other innovations that may be more well known, like the Cradle device, which is highly accurate and well suited to use in LMICs, and includes a traffic light warning system to inform care and emergency referral decisions. So throughout the landscape, we kind of profile these different innovations. When we consider risk triage and management, there's also room to think more about different use cases that occur at different gestational ages. This figure speaks to that as well. So among women with suspected PE, there are tools that support risk assessment and inform care decisions in the first trimester to support ruling out risk, for example, as well as later in pregnancy to inform decisions around timing delivery and administering care. So as we consider these commodities that are available at different stages in the care pathway, they each have different use cases and potential benefit. This figure also speaks to postpartum preeclampsia, which is another important and often neglected part of the care pathway that we've also mapped here. So we could go to the next slide, speaks to our access barriers. So Unitaid uses as it considers across all areas of work, barriers to access and care, barriers to access to particular innovations. We have this 5-point access barrier framework, begins first with innovation and availability. So as part of the landscape assessment, we were identifying, well, what are the barriers across these different dimensions of access? And beginning with innovation and availability, we know that investment in maternal health and R&D is hampered by things like the low profit margins that could be expected from investment that stop innovators from innovating in the space. Also, the higher cost and complexity of some of the products for preeclampsia in particular, and overall lower donor investment. Also, innovation is hampered by the fact that there's still an incomplete understanding of the etiology of preeclampsia, eclampsia as well. On the affordability side, so barriers that relate to cost, some or most preeclampsia products are procured by governments. We know there's a lot of competing demands for those budgets and what they could be purchasing. In terms of some of the innovations we spoke about, there's a higher cost when it comes to preeclampsia biomarker-based tests, some ultrasound devices, for example, and some BP devices too are on the higher cost side. There's also affordability challenges at the patient level with out-of-pocket costs for care, lost wages when you go to seek care, and those create barriers to going to ANC, to completing referrals and taking specific tests. When it comes to quality, there's evidence of low-quality medicine, so it'll be great to hear Pete talk about that in more depth. There's also challenges with magnesium sulfate that's available, often being expired given its lower use. BP devices that aren't validated for pregnancy is another concern, or they're poorly maintained, so less accurate. And then going back to some of the quality and related to the supplier side, there's less quality assured suppliers of different essential PE medicines, and also weaker regulatory capacity systems, sometimes in LMICs that complicate availability as well. So when we go to supply and delivery, this also links, we see, a real problem with stockouts, with gaps in commodity availability due to weaknesses in the procurement and supply management systems in countries. In some countries, there's issues with essential medicines lists being out of date, not including some of the newer recommendations around medicines like low-dose aspirin, calcium supplements, antihypertensives. And lab facilities are sometimes not equipped when we consider some of the newer laboratory-based PE tests to be able to support that kind of testing. As we look to the demand and adoption barriers, some of the challenges relate to the fact that women often present late to care for antenatal care. Many of the interventions that have promise for prevention need to be started early, so it's a real challenge. There's also challenges with healthcare workers being less abreast of the latest guidance or not adhering to some of the guidelines, so room for strengthening practices there. Also gaps in terms of research and evidence, operational research on what models of care may be best suited to different settings and building in some of these newer innovations. And then challenges on the referral network side of referral systems existing to get women to higher level care facilities when they need it, when risk is detected. So we can go to the next slide. That's a look at, I know there are a lot of different barriers, but that captures a good bunch of them. And this last slide speaks some to opportunities that we see to improve preeclampsia care. So again, this was the product of a lot of stakeholder consultation. And the goal is to kind of identify what some of these priorities are. And I won't be able to go into a lot of depth on each of them today, but when we publish the landscape, we'll be sure to disseminate it widely and through the Reproductive Health Supplies Coalition networks. But to speak to some at a high level, we see the value of focusing on innovations in different kind of areas of the care pathway, that there's clearly a need to focus more on identification of preeclampsia risk, as well as preventive interventions during ANC. So that includes, focus on validating tools like BP devices for use in pregnancy, improving adoption of low-dose aspirin and calcium supplementation for women at risk, better use of devices for ultrasound, particularly point-of-care tools, as well as strengthening the capacities of healthcare workers to screen for maternal risk. Also focus on raising awareness among healthcare workers and communities about the ANC benefits of attending in the first trimester, to also address cultural and health system barriers that limit access. And then a focus around early engagement in ANC can include some kind of innovative models like group antenatal care, for example, other kinds of participatory women's groups, or self-care innovations. We see a lot of potential for that from our conversations and engagement. In terms of the next stage being more management of women with suspected preeclampsia, that's where innovations like these new blood-based biomarkers have real potential to improve both triage of women with suspected preeclampsia, but also to guide these decisions around management and timing of delivery. There's also diagnostic algorithms that have been adapted to use in low resource settings that could integrate some of these biomarker-based tests and improve care. And there's also more upstream now, but we've profiled this in the landscape, some promising preventive and treatment therapies that are in the pipeline that hold potential, as well as more urine-based biomarker tests that could add value for different use cases. And then when we consider also more cross-cutting needs, we spoke about the need to engage communities, focus on advocacy and promotion of use of these underutilized commodities. There was also a need to develop and also utilize some of the great target product profiles that have been used to guide product R&D, alongside greater investment in maternal newborn health R&D. In terms of health system strengthening, support to procurement and supply management systems is really critical as well. And then we see, with preeclampsia in particular, we see opportunities to focus not only on the care pathway for the pregnant women, but to consider also linked care pathways for infants that are born preterm, improving the availability of essential commodities like antenatal corticosteroids, things like that, would also be beneficial to include in some of these packages of care that could be taken forward. I think I've spoken to many of these across the figure, but happy to answer any questions, and it'll be great to be able to share this landscape. We'd hope to be able to publish it ahead of today, but it will be coming out around mid-September, and we'll be able to make sure everyone sees it, and happy to answer questions. And I think I'm happy to share my email also in the chat if there's points you'd want to raise based on what we've presented. Thanks so much.
Elsie, thanks for the very clear and illustrative slides as well. There are a couple of questions in the chat, and maybe the ultrasound question we can leave for later, because I'm suspecting Josh may mention that. But I think there's one point about magnesium sulfate availability in facilities, and I don't know if you could say a few words about what we know about availability in the field for magnesium sulfate.
Yes, happy to. I think, and I see that the comment in the chat around how there's only on average 50% availability across facilities in key countries. So that's, yeah, really, really important. And in terms of interventions to address that, I think, we've some discussion in the landscape around like pooled procurement type strategies, working to potentially advance local or regional manufacturers of some of these essential maternal health commodities. And also from other webinars from the Reproductive Health Supplies Coalition, there's some innovations on the supply side, like the UNFPA Supplies Matching Fund, opportunities like that could also improve access. But I think a lot of it too is working at the national and subnational level to understand why some of those stockouts occur, how it could be better, procurement could be better consolidated and taken forward in a way that we avoid some of those availability challenges. But yeah, thanks for raising that work. And I know Samantha at R4D, you've done a lot of work in this space. So it's great you asked that question.
I think there's one more question specifically about Unitaid's focus as to whether Unitaid is more focused on R&D, product innovation, or whether it is also focusing on improving access to established and recommended products.
Yeah, so Unitaid definitely focuses on both. We say we focus from late stage product development through market entry, through introduction and a transition to scale. So certainly, yes, focusing on not just new products, but underutilized products that could be better used and addressing those access barriers as well.
And I suspect that would cover your response to Jeff's question around different magnesium sulfate regimens as well, I suppose, as a way of improving access, right?
Yeah, certainly. And those trials on those alternative and simplified regimens, yeah, we certainly profiled that work in the landscape as really exciting and potentially, overcoming some of the challenges at the healthcare worker level that we were speaking about. So great to see the outcomes of those trials.
So thank you very much. Please stay at the webinar. We may come back to you. I'll now move on to Josh Vogel. Josh is the co-program director for maternal, child, and adolescent health at Burnet Institute. Josh has been working on maternal health projects, both in terms of primary research and normative guideline development, supporting WHO guidelines for several years now, and implemented a number of trials and observational studies. He has received numerous awards, as you can imagine. So Josh is going to talk about something that is, I think, becoming slowly more widely known about in terms of screening and how we can assess women at higher risk of preeclampsia. Josh, over to you.
Thanks, Metin, and thanks to Milka and the team for the invitation. Metin, you're seeing those slides okay? Great. And yeah, I hope this is a natural progression from Kelsey's really fascinating and really important presentation. So I do just want to start, though, by maybe centering our attention on the women and the families that are affected by preeclampsia. And if you ever have the chance to hear Koiwa Koilabi speak, she is just an incredible advocate in this space. She set up the first consumer organization on preeclampsia advocacy in Ghana called APEC. And she has had just the most horrific experience with this disease, having lost 3 of her 4 children to it. And has become just an incredibly potent advocate for change. And I think really important in whether it's R&D or research or implementation that we do bring people like Koiwa into those conversations, because ultimately they're the most important of all stakeholders. We probably don't need to dwell too much on the background history, but one thing I want to flag about preeclampsia is that this is a disease that has its origin very early in pregnancy. And actually, at the time that the placenta is implanting and developing, the disorder of preeclampsia can be traced back to the early in pregnancy. In that sense, focusing on risk screening and prevention activities as early in pregnancy as possible is relevant. As the disease progresses, in terms of endothelial dysfunction, raising blood pressure, and ultimately organ systems being affected, as Kelsey touched on, this is often a very difficult problem can't really be reversed and is usually in a situation where only delivery of the baby and the placenta is the cure. So the degree to which we can identify and prevent this disease early is going to be the most bang for buck in terms of public health benefit. Kelsey presented some of these numbers, but just to maybe emphasize a couple of other factors, that the majority of these nearly 7 million pregnant women who are developing preeclampsia each year, the vast majority of them live in Africa and Asia, and there is very limited evidence on the degree to which risk screening and prevention with aspirin is actually being used. But what evidence is out there suggests that the vast majority of these women don't know. They don't know that they're at risk. They're not offered opportunities to prevent it. To that sense, some significant proportion of these 7 million cases are preventable. And one of the activities that we'll be doing over the next couple of years is trying to actually perform some economic modelling in terms of what economic and life-saving benefits can be conferred by scaling up risk screening and prevention in low middle-income countries. I think there's also been a too narrow focus on preeclampsia as a maternal health issue, and obviously it's one that occurs in pregnancy and affects pregnant women and babies. But it's a much broader issue. Those women who experience preeclampsia are much more likely to develop multiple different non-communicable diseases in later life. And that period where they experience those diseases such as hypertension, stroke, diabetes, cardiovascular diseases, that's actually a great deal longer than pregnancy itself. And in that sense, preeclampsia is a maternal health issue, but it's also a women's health issue and a non-communicable disease issue. And I know many of you work in countries where governments are increasingly concerned about the burden of NCDs. I've returned recently from Ghana on one of our project sites in the Pearl study, and an observation there has been that the average BMI of pregnant women has been raising over the last 20 years, and that's something that I'm sure a lot of countries are observing, that obesity is on the rise, and that's a significant risk factor for preeclampsia as well. So I think there's some secular trends that are probably pointing towards that preeclampsia as a disease burden is getting greater rather than smaller over time. So this is just a very simple schematic to try and help orient ourselves and just picking up on a few key interventions. I'm not going to be talking about calcium today, but calcium is a supplement for preeclampsia prevention that's aimed at women who live in areas where there's low dietary intake. So typically, we're not making a decision about individual risk at the level of the woman. It's more a policy level decision at a jurisdiction or a government level. What I'm focusing on more today is this individual level risk screening to try and identify those women who are at high risk of developing preeclampsia and whom we can offer low-dose aspirin to, and hopefully avoid all those downstream requirements of extra monitoring, additional care, often a preterm baby, or the need for management of preeclampsia. And just to sort of illustrate what sort of proportions we're talking about, obviously different risk screening tools will identify different proportions of women as high risk, but some tools are converging around the sort of 10 or so % mark in certain populations. So that's the sort of scale that we want to think of in terms of identifying high-risk women. So ideally, what we'd like to happen is that a woman's attending ANC in early pregnancy, and the provider's got a way of identifying accurately those women at high risk, and then offer those women low-dose aspirin starting as early as possible. So evidence points towards the fact that starting aspirin before 16 weeks would be ideal. Let's just focus first on number one, about how do providers actually go about identifying these women at high risk. Now, at the moment, there is not really clear consensus across international organisations that produce guidelines on exactly how to do this process. So a number of these guidelines, NICE, WHO, ACOG, a few others, they're focused on history-based risk factors, asking women a set of questions about their medical history, and then trying to organise women into groups of high or low risk, or high, moderate and low risk on the basis of that. Now, those organisations are not necessarily in full agreement on what is a risk factor and what is not. They overlap, but they aren't necessarily the same. So depending on what guideline you look at, you might have a different answer as to what history-based risk factor screening actually looks like. Now, what's starting to come into some guidelines, for example, ISSHP and the FIGO guideline, is the addition of some of these special investigations that Kelsey mentioned, things like bringing uterine artery pulsatility index, placental growth testing, these sorts of special investigations into the risk screening process. And I'm going to speak to that in more detail in a moment. I will point out that WHO has a recommendation on aspirin, but doesn't actually have a specific recommendation on how risk screening should be performed. So they identify a list of a non-exhaustive list of history-based risk factors. You'll see a similar, inconsistency if you look at national guidelines across many low middle income countries as well. Now, if you ask me, I'd say, look, history is better than nothing, but it doesn't necessarily perform very well as a tool. There are several reasons for that. One is that these risk factors are not equivalent. Even when we say these risk factors are all high risk factors, they have quite different magnitudes of risk. The second is that we're applying relatively arbitrary thresholds. So to say that a woman who's 39.5 is low risk, but a woman who's 40 years and 1 day is high risk, you can sense how crude some of these divisions are. And also they ignore the fact that these risk factors often interact, and women who have more than one of these maybe have a greater risk than more than just 1 + 1. It's been shown in research that these tools don't identify the majority of women who will go on to develop preeclampsia, and they have a tendency to identify a lot of women as high risk who don't go on to develop preeclampsia. So it has a reasonably high false positive rate. Now, Metin, myself and others through the AIM project, Accelerating Innovation for Mothers, we've been trying to tackle this problem. Our colleagues at the Policy Cures Research Group have actually conducted a landscape analysis of what's in the R&D pipeline for preeclampsia risk prediction. And you can find the report on the Concept Foundation website. And it's exciting in the sense that there's a lot of interesting tools coming through the pipeline. And there is a predominance of different types of biomarkers in that R&D pipeline that are being investigated. Another interesting aspect of this pipeline is that the combination of different tests, be they imaging, biomarker history, and so on, being combined into a multi-parametric test is also an area of active research. What's quite interesting about these landscape analyses is you find there might be a lot of activity, people moving in a lot of different directions, but there isn't necessarily a organising principle or a target or a strategy about where we want this R&D process to go. And in that sense, the AIM project has been focused on the target product profile development. This is about developing a document that developers, funders, others who are involved in research on preeclampsia risk screening, what are we actually aiming for in terms of the real world public health need, particularly for limited resource countries. We have this TPP out for comments now. I'd really encourage everyone, please do use this QR code or the link to take the survey. It's open for the next few weeks. We really want to get a sense of what the community thinks that a target product profile should look like in order to inform those R&D efforts into a more efficient direction. But stepping back from the R&D pipeline, what do we know right now? And while there are lots of different prediction models that are out there in the literature, one that bears specific mention is the Fetal Medicine Foundation risk screening algorithm, the FMF algorithm. And this is a multi-parametric test. And it appears to have better performance in terms of accuracy metrics as opposed to other models, particularly other models that are based on history-based risk screening, risk factor screening alone. The FMF algorithm, you can find a calculator freely online at the website in the bottom right-hand corner. It's intended for use in pregnant women at 11 to 14 weeks of age, gestation rather, and it's been created and validated in high-income country European settings. And it generates a risk score where a woman has a specific numeric risk of preeclampsia. Now, it's making that calculation using a Bayesian model, and it's collecting information from history, mean arterial pressure, a UTPI, uterine artery pulsatility index from a Doppler ultrasound, and a biomarker test, ideally PLGF, but if not, PAP-A test. As you can see from the box on the right, these all require some sort of special investigations, specialist staff, laboratories, and with that comes complexity and additional expenditure. In the UK, the group at the Tommy's Centre for National Clinical Improvement have a platform called the Tommy's Clinical Decision Tool. And this tool is for antenatal risk screening. It does a lot of things. It's intended for health workers to screen for risk in preterm birth, in fetal movements, in placental function. And that module on placental function is the FMF algorithm. It was launched in 2022, and some tens of thousands of women have undergone screening with this instrument. So we have some sense of how the FMF algorithm is performing when used in various populations in the UK. So what this is showing is that the detection of preterm preeclampsia is significantly increased within the Tommy's tool using the FMF algorithm approach. So for these two outcomes, effectively doubling of preeclampsia detection. I should point out that the FMF algorithm is primarily focused on predicting preterm preeclampsia, which is the rarer but more aggressive and deleterious form of preeclampsia. It doesn't perform as well for term preeclampsia. And with that improvement in risk screening has come a concomitant increase in the coverage of preventative aspirin, which of course is the really effective prophylactic that we want women to have. So in summary, around risk screening, history-based risk screening is widely recommended. Doesn't necessarily work as well as we might like, but it's certainly better than nothing. While the FMF algorithm is the best performer in the literature, it's currently difficult to implement in resource-limited settings. There are new risk screening tools in the R&D pipeline, but the question we're trying to answer within the PEARLS project is whether that tool, Tommy's tool FMF approach, could be adapted for low middle income countries for preeclampsia risk prediction. I want to talk a bit about aspirin, and sometimes I think aspirin's the sort of forgotten child of the maternal health commodities world, and it certainly doesn't deserve to be. This is an incredible drug, obviously been around for a long time, and you would think available in every pharmacy in the world. And in the case of preeclampsia prevention, when offered to women at increased risk, prevents preeclampsia, prevents perinatal death, prevents preterm birth, and reduces small for gestational age. Now, this comes at a price in the sense that aspirin is an antiplatelet agent. You would expect some degree of increase in bleeding. But the evidence is actually not particularly clear, largely because trials have not done a good job of quantifying that blood loss. But there is some suggestion that there is an increase in postpartum hemorrhage. But again, that has to be weighed against the significant benefits of preventive aspirin. And WHO recommends in favour of this intervention. Unfortunately, again, there's not a lot of consensus across guidelines in terms of what the right dose is to use and when to use it. Everyone agrees it should be used, and ideally you should be using it early in pregnancy. But there's some dispute as to whether the 75 or 81 milligram aspirin dose or the 150, 162 milligram dose is the better option. In fact, here in Australia, clinicians are using 100 milligrams, I guess, sort of somewhere in the middle. And you can see on the right there that there's some distinction in terms of when people recommend you should start it. If you dig into the WHO recommendation specifically, they've come down on the side of 75 milligrams for two reasons. One is that they do not feel that it was clear or definitive that the 150 milligram was definitively superior to the 75. They acknowledge that it may be, but they felt that that could be answered by a dose comparison trial. The other consideration was the concern about the bleeding risk. Presumably, or theoretically, one would have a greater bleeding risk with a higher dose. But again, that's never been quantified or shown. So they've called for, as a high research priority, a comparative trial of 75 versus 150, both to establish superiority of benefit, but also to determine whether there was any difference in risk of postpartum bleeding. And again, that's a priority that the PEARLS trial is addressing. Our friends at Concept Foundation are actually doing an ongoing mapping around aspirin availability. So this is preliminary, but some themes, including that doesn't always appear on WHO, on the essential medicines lists, including the WHO essential medicines list. It's listed, but not for the indication of preeclampsia. It seems there are manufacturers around in multiple continents, and manufacturing costs are relatively low. So one would think this is a reasonably permissive environment in terms of trying to help governments and health services access and scale up aspirin. However, that is certainly not the case right now. There is very little evidence on what the coverage of aspirin is in low middle income countries. We have a study running in 10 countries in the Asia Pacific at the moment. This is one of the questions we'll be able to answer. But this study in front of you from Ethiopia is probably the scariest paper I've read in the last couple of years. It was a simple cross-sectional study. They looked at 395 women who presented to a hospital and had preeclampsia. They wanted to know how many of those women could have had aspirin or should have, and how many did. So 195 of those women, they had an indication such that they should have been offered preeclampsia early in pregnancy. So only 50% of those women under the current guidelines in Ethiopia could have been identified early. But actually in the whole population, only 1% of women got aspirin at all. And this is a population in which the perinatal mortality rate is 12%. So simply by improving the access to whatever dose of aspirin was available, using whatever risk screening approach was available in this country right now, would result in preventing preeclampsia cases and saving lives. That's not to say that we shouldn't try to improve risk screening and optimize aspirin dosing. So that's kind of the picture of the field, but these are the big questions that are remaining. We still need to solve how best or how accurately we can identify women at high risk in resource-limited settings. What's the optimal dose in terms of benefit and bleeding risks? And let's go further. Let's look at the implementation questions. What are the barriers to the risk screening and aspirin use, and how can we overcome those? And to what degree is risk screening and aspirin use cost effective? Well, if we assume that aspirin is a drug that can not only prevent preeclampsia and preterm birth, but also prevent women from experiencing NCDs later in life, you would expect that to be highly cost effective. So the PEARLS trial will answer these questions. It's in 2 phases. One is a cohort study to validate the Tommy's tool in 3 countries, using a risk screening adapted approach of the Tommy's tool, using history and blood pressure only, and gestational age based on a point of care AI ultrasound device. So this is about 16,000 women, and in addition, we'll nest evaluations of barriers to risk screening. Once we've finished that cohort and we've established how best to identify high-risk women, we'll move to a trial, comparative trial of 150 versus 75 milligrams of aspirin with nested evaluations on barriers to aspirin and risk screening and cost effectiveness of those interventions as well. And just to close, Metin, you mentioned the AI ultrasound in the Q&A with Kelsey's session. I haven't spoken to that in a great deal, but in order to try and optimize point of care gestational age estimation, we've brought in one of these innovative devices, one produced by Intelligent Ultrasound, which is actually a device that can be used by a non-expert, a non-sonologist. It uses a handheld ultrasound probe and an AI algorithm to accurately estimate gestational age. These are experimental, they're exciting devices, but we're also doing nested research to see how these can actually be integrated into preeclampsia risk screening and into maternal health care more broadly. So thank you very much, really appreciate the time, and please do complete our survey to try and improve the TPP.
Thank you very much. And I think you provided a very nice overview of screening challenges and missed opportunities. There is one question from Chinedu at Solina Center for International Development and Research in Nigeria. And I think the question is about how do we operationalize these risk screening approaches in primary healthcare settings in low and middle income countries?
Yeah, thanks, Metin, and thanks for the question. Primary healthcare settings is a real interesting problem because obviously these settings will be seeing large volumes of women, but maybe not large volumes of high-risk women. I think a significant challenge that we're all aware of is actually encouraging women to come in early. When I look across guidelines at national level, there are plenty of national guidelines, including in low middle income countries, where they're saying that all women, including women at primary care, should be undergoing some sort of history-based risk factor screening. So I think there are things that can be done now in terms of improving that. But it goes back to, I think, Kelsey's earlier point that there's a need here for operational research about how that we can bring that into primary care at scale. Now, in terms of new and innovative technologies, I think the question still remains whether, even if they're very fancy, exciting point of care tests that don't require expertise or laboratories, are they actually going to penetrate to primary care settings? I think that's still an open question. And it's certainly one that needs to be factored into developers' thinking, when they're actually producing these products. Are these only ever going to work in tertiary settings, or can we take them to primary care where so many women give birth and receive antenatal care?
Josh, thank you. And let's move to, I think there was one question. A couple of those diagnostics biomarkers also state that they can use for treatment. Any new info or work on this? I suppose identifying women who may need treatment is the question.
Yeah. Yeah, what's interesting is there's not a clear cut, Debbie, between what is a technology for prediction and what is a technology for diagnosis. And often, you know, a given biomarker may have applications in both. So many of these developers are actually not approaching it as a prevention only or as a treatment or as a diagnosis only question. They're still quite early in development and have a bit more of an open mind. So I suspect we may see some of these biomarkers finding more than one application.
Thanks, Josh. Okay, let's move to Pete. Pete Lambert is a professor at Monash University, our second speaker from Australia today. Pete is familiar to this group, obviously, and many people will know Pete's work on inhaled oxytocin, but Pete has been doing extremely important work on assessing the quality of maternal health medicines for a while, and we have been collaborating at Concept with Pete as well. So he's now initiated the Monash Quality of Medicines Initiative, and I think the main question maybe Pete may try to answer is, of the 1.1% eligible women who received low-dose aspirin, how many of those aspirins were of substandard or good quality? So Pete, over to you.
Thanks, Metin, and good morning, good afternoon, good evening to everyone. Yeah, as Metin says, what I'd like to talk about today is the work that we've been doing to assess the quality of medicines for hypertensive disorders of pregnancy, which of course include preeclampsia and eclampsia. So just as by way of some quick background, I think many of us know, I'm just getting the slides to move, there we go, that quality of medicines is an issue. It's a global issue, but it very much predominates, as with many issues of health equity, in low and middle income countries. As you can see by this sort of heat map that signifies the prevalence of substandard and falsified medicines globally that came from the systematic review conducted by Azawa et al. The reasons for this are multifactorial. Main ones include the limited financial resources in these countries to be able to procure quality assured medicines, but also the lack of regulatory capacity to provide adequate oversight of the processes for medicines registration, procurement and supply. And of course, we know that issues of medicines quality apply very much to obstetric medicines. This is a figure that I'm sure many of you have seen from the WHO systematic review that assessed the quality of medicines for life-threatening conditions of pregnancy. The results were quite alarming, particularly in the uterotonic class of medicines, and many of us have been involved in trying to understand that better and put in sort of mitigating strategies to improve the situation. Worth noting that in this study, the only drug that related to preeclampsia and eclampsia was magnesium sulfate, which, as you know, is used to treat eclamptic seizures. And while the prevalence of poor quality was relatively low, these data were generated from quite a low number of samples as well. And of course, there are many more medicines that are used in hypertensive disorders of pregnancy that weren't captured in this study. And both Kelsey and Josh have mentioned that one of the reasons why this is so important is because hypertensive disorders of pregnancy are indeed the second leading direct cause of maternal mortality, and as I think was mentioned, in some countries, even the leading cause of maternal mortality. So this is the background through which we thought it was important to do a more comprehensive look at whether medicines in this area are affected by poor quality issues. And we did this by initiating a PhD project. That project is being led by Pooja Mahajan, who's on the call today as well, and has been doing a fabulous job of progressing through this workflow. The project is also co-supervised by our colleagues at the Burnet, including Josh, who you've just heard from. So the project that we've initiated is divided into 3 stages. The first one was to conduct a systematic review of the existing literature to see what evidence there was or wasn't to indicate that medicines for hypertensive disorders may be an issue. That work has been completed, and I'll speak to the results of that in a moment. The second stage, which is ongoing, is that we are conducting a quality of service, quality survey of medicines in this area, targeting 4 LMIC countries, and that is progressing well. And then the third one is really dependent on stage 2. So if we see any significant quality deficiencies in the classes of medicines used to prevent or manage hypertensive disorders, then we'll look to conduct a health economic evaluation of the potential financial impacts of those poor quality medicines. I think we're beginning to realize that these health economic evaluations are becoming a really important advocacy tool, particularly when talking to local governments, that it's important not just to focus on the cost of the medicines, but to focus on not just the health impacts, but the financial impacts of the sequelae that flow from inadequate care if poor quality medicines are used. So to look at the first part of the project, the systematic review, one of the first aspects that we did to initiate this study was to determine the medicines that were going to be included in the review. You can see we identified 9 drugs there that range from calcium supplementation and aspirin for prevention through to magnesium sulfate for prevention and management of eclamptic seizures. And we derived this list from WHO and national treatment guidelines. We went on to conduct the systematic review according to sort of standard best practice in this area. I'm not going to go into details, largely because it's not an area of which I have any great expertise, but to and was very much supported by our Burnet colleagues in conducting this. But just to highlight some key aspects of this, firstly, the review included not just peer-reviewed journals, but also reports from the grey literature. And we applied no date limits to the screening of articles, so that we went back as far as there was reports to include. Also, the studies were agnostic to indication. And by that, what we mean is we didn't just look for studies that were based on the management of hypertensive disorders of pregnancy. As I'm sure most of you are aware, the vast majority of maternal health medicines are repurposed from other indications and therefore are used much more widely across a number of therapeutic areas. So we focused on the medicine itself rather than the application for use. What was interesting to me in the actual screening of the studies was once we had done the triage and excluded studies for based on relevance or duplication and eligibility criteria, the actual number of studies we found was really quite few. So 33 studies were included, which is actually quite a small number given the numbers that were originally identified. So what were the results of the studies? Well, the first one was just how many of those studies that we included in the review actually identified issues of quality. So you can see here the yellow and red territories are those countries in which the studies were conducted. And the red ones are those where quality issues were identified, whereas the yellow ones were where there were no quality issues noted. So you can see the vast majority of the studies found some issues of quality. You can also note that some of the studies actually found quality issues in high-income countries, specifically in this case it was the US, Germany, and also Yugoslavia. And But it's worth noting that those studies were actually quite old. So they were conducted in the 1980s, so perhaps are less relevant in this context. To look at the data in some more detail, first thing to notice in the left-hand column is that we actually found quality issues with 8 of the 9 products that we had originally identified to be included in the review. And then moving to the right-hand side, the actual quality issues that were most common was API content, that's the active pharmaceutical ingredient. So that means the drug content of the products, and also the related substances or impurities. So that would typically be low drug content, or high impurity content, which was the issue there. But it was not limited to that. And you can see that there were other elements such as physical parameters or pH, or even in one case in the magnesium sulfate microbial contamination. But again, this was based on relatively few studies. So just to summarize, what we found was that there was evidence of poor quality in the classes of medicines used for hypertensive disorders of pregnancy. 88% of studies indicated that. While there were some issues in high-income countries, they were generally quite old studies, and nothing had been detected more recently. Interestingly, the products tested came from a range of source countries. So there wasn't one manufacturer or one manufacturing country that was leading to this. As I say, the most common deficiencies were low drug content or impurities. And sort of reading between the lines on some of these studies, we couldn't see anything that was there was quite limited information on anything to do with the root causes of these quality deficiencies. But we could see that there were clearly some issues of manufacturing quality, and in the case of aspirin, some evidence of degradation. This study has now been published, so if anybody wants to take a deep dive, please do so, and we'd more than welcome any questions that you may have. Now, subsequent to completing this study, I was actually invited to participate in some work with the Therapeutic Goods Administration. So the TGA is the National Regulatory Authority in Australia, and they have a program which provides laboratory testing support to Pacific Island nations, actually 12 Pacific Island nations and Timor-Leste. This is to assist with their pharmacovigilance activities, which are quite difficult in these territories. The service they offer is quite limited, both in terms of the number of samples that they have capacity to test, but also the therapeutic areas that they focus on. So they focus on NCDs and anti-infectives, unless there is a specific reason to look at other drugs, for example, the diethylene glycol issue in cough syrups that happened more recently. Now, the data from this testing is not generally published, but in my conversations with them, I became aware of some data that was of relevance to this meeting. So they've given me permission to present it. So it's really just to say that of the testing that they've been doing, and this program has been live since 2017, the class of drugs where they find the highest prevalence of poor quality is actually antihypertensives. And they see a failure rate of around 40%, which is obviously quite significant. It's driven mostly, but not exclusively, by poor quality enalapril. So again, this is another sort of indication that the class of the medicines used for hypertensive disorders may have an issue if we look more closely. So then just finally to move on to the second stage of Pooja's PhD project, and that's the quality survey of medicines that we're conducting currently. This is being conducted in 4 countries, Ghana, Nigeria, Malawi, and Nepal. And we're incredibly grateful to our partners who are helping us with gaining local approval to do these studies and the sample collection on the ground. So that's the USAID PSM program, who are helping us in sub-Saharan Africa, and GLOMED in Nepal. So GLOMED is a non-profit NGO research organization focusing on global health, who have been kind enough to assist with this work in Nepal. And Dr. Suraj Patari is on the call this evening, I believe. It's not feasible for us to collect all 9 medicines that we had in the systematic review. So we've pared that down to just 3 medicines from each country. We're focusing on aspirin, magnesium sulfate, and whatever the most commonly used antihypertensive is in that country. That doesn't necessarily mean the first line product in the guidelines. It's the drug that through engagement with local stakeholders we are told is most commonly used. And that has been nifedipine in Ghana and Nigeria, methyl-dopa in Malawi, and I believe that will also be nifedipine in Nepal. Just to speak to Josh's point about the appropriate aspirin dose, in this, in our sampling protocol, we are being agnostic to dose of product that we find on the ground. So I think ideally we're looking for low dose aspirin, but if the only aspirin that's available is a higher dose product than the 75 milligrams, then we will collect that as well going forward. So we'll get some idea from this study as well is what is the dose range that's available on the ground across these 4 countries. The status of the program so far is that the sample collection is complete in the sub-Saharan African countries. PSM have done a wonderful job for us in doing a really comprehensive coverage in each of the countries. So we've really got quite a lot of work ahead of us in terms of the analytical side, because we have a large number of samples, but hopefully that will give us a really good insight. The samples for Ghana will be first up, and then the Nepal study is following on from this. So we're just going through the local approvals and study preparation at the moment. Hopefully we'll have all sample collection completed by the end of the year, and we'll be able to report the results early in 2025. So I'll finish there, just acknowledge all of the teams that have helped us to do this, both across Monash and Burnet, with Josh and Annie co-supervising Pooja's work, and Meghna, who helped with the systematic review, Siobhan, Brittany and Rebecca in the PSM program, and I think Brittany is on the call today. Siobhan, of course, has moved back to USAID, but she was really instrumental in getting the project up and running, and Dr. Suraj from GLOMED. So thank you.
Pete, thank you very, very much. And you are the first speaker to get claps from Milka, so I think that's a special recognition of your presentation. There are a couple of questions, and some of them relate to the country of manufacturing for the products that you showed us the results for, and specifically having these high-income country poor quality results, which is probably not that common. And then India having no poor quality or no quality issues in the map that you showed. But I think maybe I want to ask a more general question. And is there any evidence that you are aware of about things improving? Because sometimes when we refer to an evidence that's 30 years old, we kind of dismiss things and say it's old, especially when you mention Yugoslavia and countries that don't exist anymore. But I'm getting the feeling that especially in maternal health medicines, every time you have a bunch of medicines tested, we find 40%, 50% failure rates or substandard medicines. And I don't know if you have any insights into whether over the years there has been less substandard medicines, or we are just continuing in the same sort of failure rate. So over to you.
Yeah, I think it's a difficult one, particularly for the medicines, for the preeclampsia and eclampsia medicines, just because there's been so little testing and the studies typically were not large numbers of samples. So it's difficult to understand what the baseline was against which you can make a judgment as to whether things have improved. I think the other issue is that the amount of testing that's being done now certainly for sort of uterotonics is much higher. And I think there is an element that the more you look, the more you find. We're also doing more sophisticated testing sometimes. I think one of the things that we have noticed in our testing is not all quality issues are picked up by the pharmacopoeial tests that are generally used to assess these. So sometimes they will not see impurities that are in these medicines. We've seen that recently with the tranexamic acid work that we've been doing, which obviously you're aware of. So my sense is it's difficult to really make any definitive comment on the trends that are existing, other than to say that there clearly is still a significant issue, and there's lots of work to do. I'm not sure if there's anyone else on the call who wants to make an additional comment to that, but that's my sense at the moment.
Oh, thank you, Pete. And there's one more question around any data on financing procurement channel for the drugs that are of low quality.
Yeah, I just the earlier question, I think the sampling was done across both public and private sectors, just to confirm that point. Certainly from the systematic review, that wasn't an element that we looked at to understand how or through which channels they're procured. And I think often that's difficult to track, particularly when you're sampling at the point of use, to understand if they've come through a formal procurement channel, or sometimes, waivers are issued to overcome stockouts, and facilities or regions and districts are free to purchase from where they can, rather than necessarily from registered products through the national procurement chains as well. So I think that I mean, it's certainly a very relevant question, but it's not easy to determine always.
Thank you. I just want to raise, Debbie, I'll come back to you, sorry. One more thing, we obviously rightly focus on substandard medicines, but I think we shouldn't ignore the fact that devices can be of substandard quality as well. And in this context, we need to perhaps pay particular attention to blood pressure measurement devices, and how we can actually have properly calibrated and devices that are up to standard. And I think in other areas, other devices will also come into play, but we shouldn't neglect devices in this context. Debbie, please go ahead.
First of all, these were some great presentations. Thanks very much to everyone. And the question is to Pete, but one of them may go back to another person as well from earlier. For when you're doing your sampling, Pete, sorry, can you hear me?
Yes.
Yeah. Somebody unmuted themselves, yeah.
Okay, sorry. So both for nifedipine and mag sulfate, will you be identifying the presentation like a 50% or dose for mag, or which nifedipine dose you are actually collecting? And I ask this because some of the issues that we've been seeing for nifedipine is that there are multiple long-acting, short-acting, et cetera, of the meds that are available. And nifedipine isn't really the recommended dose, but countries do seem to be using it. So will you collect some of that information to help us better understand what's actually being used, in addition to the quality of the meds that you're sampling? So that's one question. For the MAG, I ask it because somebody earlier mentioned that there was still concern that, I think actually it was Kelsey, in the baseline, that
that it was difficult. The mag sulfate dosing was difficult, but I really, at least what I've seen from data from our EUVs, et cetera, is that most countries are not using the 10%, 20%, 40% mag sulfate anymore, but the majority of them are using, a dose that's fair, or a presentation that's fairly easy to dose. So long-winded, actually simple questions on whether you will identify dosage and presentation. Thank you. Oh,
yeah, thanks, Debbie, and absolutely. So again, with all of the drugs that we sampled, we didn't specify a presentation to collect, so we collected what was available. I think also we have, but just because of the volume of samples that certainly PSM have collected for us, we should be able to present exactly what you asked there in terms of what is a presentation that has been collected, and we can also probably further disaggregate it by what facility, whether it was from a pharmacy, whether it was from a smaller clinic, whether it was from a tertiary or secondary hospital as well. So, I mean, it wasn't the primary purpose of the study, but we can absolutely present that breakdown as well, and make sure that's available to everyone.
thanks, Pete.
Thank you, Pete. Any other questions, clarifications? Milka, anything on your side? Samantha Durdock,
Samantha.
please
Harvard
go
Yale.
ahead.
Hi, everyone. Pete, this was great. Thank you so much. Quick question, getting our minds kind of in the solutioning phase a little bit. One thing we see quite commonly across MNCH products that have multiple use cases. So I'm thinking of like amoxicillin, gentamicin. We're looking at azithromycin right now as well for maternal sepsis. We see this challenge where there are quality issues for products that can have a really competitive supply base that are primarily procured by governments that have policies where, we procure from the lowest bidder. So that kind of has this race to the bottom price component, and it makes it really difficult for quality assured products or products of maybe better quality to compete in that type of dynamic, when you have a lot of suppliers, when there is that race to the bottom. So I'm just curious if you have any thoughts, since you've been in the weeds of the data and seeing all the quality concerns with aspirin. I feel like this product will kind of fall in that same bucket of products where there's a lot of competition, race to the bottom in price, really difficult to address the quality issue from a supply demand perspective. So yeah, just curious if you had any initial thoughts or ideas of how the global markets could maybe try to address some of these challenges.
I think the challenge that you've just outlined is one of the key ones around quality, and I'm not sure I have the answers. I think this is the problem that we have, is that if we want to persuade manufacturers to do WHO pre-qualification or get some other certification of quality assurance, that necessarily means that the price of their products is going to be higher, and it's difficult for them there to compete in the market. It's I really think it's a challenge. It's one of the reasons why I think some of the health economic analyses are important in just persuading national governments that it's somewhat of a false economy to just go for the lowest priced product. I think the recent paper that looked at the health economic impact of poor quality uterotonics in Nigeria and Ghana highlighted that. But I'm not sure there is an easy solution. I certainly had a discussion when I was recently with a group of the chief pharmacists from those Pacific Island nations that I mentioned earlier, and the prospect of asking them to buy quality assured medicines, which may be 5, 6, 10 times the price of the ones that they're buying, is just unrealistic given the complete constraints that they have on their national budgets for these for these medicines. So whether there are, you know, the programs like the Meds Access, where there are volume guarantees for manufacturers to allow them to supply, assuming they have a price cap, and I don't know. I think there's a lot of things going on, but I'm not sure there's a silver bullet to this.
Thanks, Pete. I think in the context of aspirin at the moment, there's no real demand for prevention use of aspirin because in many places the guidelines are not in place. Where the guidelines are in place, the guidelines are kind of all over the place. And in many countries, especially in sub-Saharan Africa, the low-dose aspirin is not in the market either. So I think for aspirin, there's still quite a bit of work to do to come to the stage where perhaps some of the PPH medicines are. Kelsey, I think one important question for you in the chat: when is the RFP coming for preeclampsia from Unitaid? Maybe you can enlighten us with that, and we can wrap up with that.
For sure, happy to speak to that. So as I was saying in my presentation, we have approval now to launch calls for proposals, but we're at the stage of kind of refining more specifically what the scope should be, and thinking about investments in the near term, but also in the longer term as well. So I don't have a specific date to give you, but certainly when it launches, I think I could say we intend to launch call for proposals before end of year. And we'll disseminate that widely. But another opportunity I wanted to plug, when the call is launched, we also publish a date for a webinar, and those are really useful. Anyone can register for the webinar, and when you register, you can also submit questions to kind of clarify the call scope, and that's really key. And we spend time in the webinar kind of bringing the call scope to life, but also like reading through the answers to the submitted questions. And I think that's really valuable and have been found to be valuable from past applicants to our calls. So we're excited to be moving forward with those calls in the months ahead, and also be publishing this landscape assessment even before the call launches.
Great. Kelsey, thank you so much. I think you've answered the most important question for the webinar. Josh, thank you. It's been a late presentation for Australia. Pete, thanks for your support as well. And thank you all for the questions in the chat. I think it has been a very participatory and entertaining intellectual webinar. And maybe we should do more of these kind of not so overexplored areas, and maybe over time it will become an overexplored area. But I think it's been great to have this discussion. Milka, over to you.
Thank you, Metin. Just to close, we're going to have a webinar October 16 on the LEAP report. As you know, we publish the LEAP report every year, and since 2021, we are including maternal health medicines into the LEAP report. The LEAP report is a fantastic tool to understand the gaps in supply of certain medicines. So I invite you all to stay tuned and receive our invitation for the webinar on the LEAP report for October 16. And as I said before, this webinar has been recorded, and I will share both the link to the recording as well as the presentations from our panelists. And thank you so much, Kelsey, Joshua, Pete. I know for Joshua and Pete, it's more than 10 p.m. At night. So thank you so much for being here with us and for us. And Kelsey, have a great afternoon. Metin, as usual, thank you so much for your leadership with the Maternal Health Supplies Caucus. See you next time. Bye-bye.
Thank you.
Thank you.
Bye-bye too.
Thank you all.